The heart is a dense, continuously working muscle with a massive, unrelenting requirement for oxygen. Coronary artery disease occurs when the vascular supply chain fails to meet that metabolic demand. To understand this failure, we map the supply lines. In this 3D model, we isolate the posterior descending artery, or PDA, which specifically perfuses the posterior aspect of the heart. Adding the right coronary artery to the model reveals its perfusion zone. It supplies the right ventricle and the inferior portion of the left ventricle. The left anterior descending artery, the LAD, delivers a critical volume of blood to the entire anterior wall of the left ventricle and the septum. Finally, the left circumflex artery wraps around to supply the lateral left ventricular wall, completing the primary vascular map. The primary mechanical barrier disrupting this supply chain is the atherosclerotic plaque, a buildup of fatty deposits within the wall of the blood vessel. The physical stability of these plaques dictates the clinical outcome. A highly stable plaque might cause predictable discomfort during a run, while an unstable plaque can trigger a sudden hemodynamic collapse. Therefore, managing coronary artery disease requires treating the coronary vessels as a dynamic, flow-limiting system vulnerable to mechanical failure. A stable atherosclerotic plaque is characterized by a thick, protective fibrous cap covering its lipid core. In this cross-section, the stable plaque physically narrows the arterial lumen. This structural bottleneck creates a fixed mechanical ceiling on oxygen delivery. During rest, this reduced flow is sufficient to meet the metabolic requirements of the healthy myocardium downstream. The physiological equation shifts during physical exertion. Conditions like tachycardia or hypertension force the heart muscle to work harder, driving up myocardial oxygen demand. When that demand exceeds the fixed supply limit of the narrowed artery, the tissue begins to starve, subjected to transient, flow-limited ischemia. This resulting chest pain is classified as stable angina. It is predictable, resolving when exertion stops or when preload is reduced using medications like nitroglycerin. Stable coronary artery disease is a fixed volume system. The vessel remains structurally intact, but its mechanical limit causes ischemia the moment myocardial demand outpaces the constrained supply. The critical pathophysiological pivot occurs when the thick fibrous cap of the plaque mechanically ruptures, exposing the internal lipid core directly to the bloodstream. This exposed core material is highly thrombogenic. It triggers an immediate aggregation of platelets, rushing to seal the injury. This massive thrombus leads to a subtotal occlusion, severely choking the artery and leaving only a minute fraction open for forward flow. Under this reduced flow, the deepest heart wall layer, the subendocardium, is furthest from the blood supply and starves first. Unstable angina is defined by this severe subendocardial ischemia. The tissue suffers profoundly, generating intense pain even at rest, but manages to survive. If the severe ischemia persists, the subendocardium undergoes cellular necrosis. As the cells die, they leak intracellular troponin proteins into the blood, reclassifying the event as a non-ST elevation myocardial infarction, or NSTEMI. This subendocardial distress leaves a distinct electrical signature on an ECG, specifically presenting as ST segment depressions and T-wave inversions. Unstable angina and NSTEMI share the exact same mechanical mechanism of subtotal occlusion. They are differentiated clinically by a single factor, the presence of cellular death. The final stage of thrombosis occurs while the expanding clot completely seals the coronary lumen, bringing blood flow to an absolute halt. With zero oxygen flow, the necrosis expands rapidly. The entire thickness of the ventricular wall dies, classified structurally as a transmural infarct. This massive, wall-to-wall cellular destruction dumps a high concentration of troponin into the bloodstream, triggering an extreme spike in serum levels. Diagnostic testing captures the hallmark electrical signature of this transmural destruction, a prominent ST segment elevation. By utilizing the principle of ECG localization, clinicians treat specific groups of electrical leads as different camera angles. Based on where the ST elevation appears, they can identify exactly which artery is completely occluded. For example, ST elevations localized to leads V1 through V4 indicate an occlusion of the left anterior descending artery. ST elevations in the inferior leads, I2, I3, and AVF, identify a right coronary artery occlusion, while elevations in the lateral leads map to the circumflex artery. A STEMI demands immediate surgical revascularization. The total loss of flow initiates irreversible, wall-to-wall destruction of the heart muscle. Dead myocardial tissue rapidly loses its structural integrity. Within the first 2 weeks post-infarct, the heart is predisposed to severe mechanical and electrical failures. The immediate clinical consequence of this detachment is acute mitral regurgitation. The patient presents with a new hollow systolic murmur and deteriorates into sudden left heart failure. Massive LAD occlusions carry their own set of consequences. Extensive anterior wall necrosis drastically reduces the contractility of the left ventricle, plummeting the overall ejection fraction. This pumping failure initiates a chain reaction. Blood backs up into the pulmonary circulation, causing pulmonary edema, and forward flow drops so low the patient enters hypotensive cardiogenic shock. The septum itself is at risk. Necrotic tissue between the ventricles can tear open under pressure, creating a sudden ventricular septal defect that allows high-pressure blood from the left ventricle to flood the right heart. This cross-section shows the most catastrophic structural failure, a necrotic left ventricular free wall rupturing outward under systolic pressure. Blood escapes the ventricle to fill and pressurize the pericardial space, causing cardiac tamponade. Post-MI mortality is driven by the progressive physical and electrical degradation of necrotic tissue. The structural stability of the resulting star becomes the primary determinant of survival in the weeks following the initial hypoxic event. The first step in acute chest pain triage is securing an immediate ECG and biomarker panel to rule out a STEMI. If the ECG is normal and troponin levels are negative, clinical suspicion shifts away from an acute rupture and towards stable, stress-induced angina. To prove this, clinicians utilize cardiac stress testing. By intentionally driving up myocardial oxygen demand through exercise, they provoke and map hidden areas of ischemia. For patients physically unable to exercise on a treadmill, clinicians take a pharmacological approach, utilizing vasodilating drugs like adenosine to chemically manipulate blood flow. This introduces coronary steal syndrome. In this diagram, the administered drug successfully dilates the healthy vessel. However, the diseased vessel is already maximally expanded to compensate for the plaque and cannot dilate further. Blood flow follows the path of least resistance. The newly widened, healthy artery steals the blood volume, intentionally starving the diseased artery to trigger a localized, measurable ischemic event on imaging. Diagnosing stable coronary disease requires actively manipulating the supply and demand ratio. Only by pushing the system can clinicians expose the hidden physical limits of the vasculature. The baseline medical management strategy for coronary artery disease relies on aspirin and statins to stabilize the plaque architecture, paired with beta blockers to restrict the heart's oxygen demand. Acute coronary syndromes require pharmacological escalation. Patients are immediately loaded with dual antiplatelet therapy and heparin to halt thrombus propagation in its tracks. Specific criteria dictate moving a patient directly to the cath lab for intervention: a high TIMI risk score, signs of hemodynamic instability, or angina that ignores medication. Surgeons choose between two primary mechanical revascularization options. This comparison shows percutaneous coronary intervention, utilizing an intravascular stent to hold the artery open, versus coronary artery bypass grafting, which externally routes blood around the blockage. Specific anatomical indications mandate the more invasive bypass procedure, such as disease of the left main artery, extensive three-vessel disease, or a depressed ejection fraction. Post-intervention care focuses on cardiac architecture. ACE inhibitors are administered to inhibit the ventricular remodeling that turns necrotic tissue into a dilated, failing chamber. Managing coronary artery disease is an escalating battle of mechanical interventions. Clinicians progress from chemically throttling oxygen demand to physically reconstructing the arterial supply, all to preserve the structural integrity of the heart.